The following podcast is part of a certified educational activity titled, Are We Closer to a Cure with Perioperative Immunotherapy in Resectable Non-Small Cell Lung Cancer? Latest evidence, current conclusions, and ongoing questions in clinical care. Access the entire activity and complete the post-test at peerview.com/AWU860. Downloadable slides and practice aids are also available.
Dear colleagues, my name is Solange Peters, and I'm the Director of Medical Oncology in Lausanne, in Switzerland. It's my great pleasure today to discuss with you the perioperative setting in the context of resectable non-small cell lung cancer, asking if we are closer to a cure in this specific scenario. And today, we'd like to discuss the latest evidence, the current conclusions that might change over time, and of course, the many ongoing questions in the clinical care. Our goals today will be to augment our knowledge, augment your knowledge on the latest data. There are lots of data produced every month on this specific topic. Improve your ability to interpret the clinical evidence supporting the various decisions you have to make for resectable non-small cell lung cancer, and equip you with the skills for devising individualized care plans, including immunotherapy in early non-small cell lung cancer. We will divide these modules into two parts. The first part will be a review, shining a light on the clinical data and supporting the use of perioperative immunotherapy. And the part two will be to try to answer together a very moving field, a very unstable field, trying to answer together the gray zone of how to prescribe immunotherapy and what are the open interrogations about it in non-small cell lung cancer. As an introduction, we have to keep in mind that breast cancer is very different from lung cancer. In lung cancer, the risk of relapse remains very high, even in very limited disease stage 1B, and this is the ACCME classification, where the risk of relapse is close to 30%. In locally advanced disease stage 3A, the probability of cure is close to 30%. So there is an important room for improvement based on the ACCME classification. Of course, we have a strategy usually of a radical local therapy, which can be surgery or radiation therapy, completed by a systemic therapy, which has the aim to reduce the risk of distant relapse, thinking of a micrometastatic disease at the time of diagnosis. To do that, we were used to use adjuvant chemotherapy, and we have added in this, I would say, strategy, the potential use of immunotherapy. Let's cover three definitions with you. What is adjuvant? Adjuvant is giving immunotherapy mostly for 1 year after the end of surgery and a variable amount of chemotherapy. Neoadjuvant is purely giving immunotherapy with chemo before surgery, and everything stops at the time of surgery. And perioperative is the whole pack, if you allow me to say, to give neoadjuvant chemo-IO followed by usually 1 year of immunotherapy. And as you see on this slide, there are lots of data, 2 adjuvant trials which have given data, 1 and unique purely neoadjuvant trials, and an accumulating number of perioperative strategy with 5 trials today presented, and still some trials in the discipline to be presented in the future under the C level here on this slide. These are the data we have in orange adjuvant, in blue neoadjuvant, and in green perioperative. So patient population is quite homogeneous, but be careful. Some use the 7th, some use the 8th ACCME classification, but basically disease which are nodes positive, or which are more than 4 centimeters in diameter. The trials capture all of them, the DFS or EFS, and some of them also capture the pathological complete response or major pathological response as primary endpoint. All of them have some level of chemotherapy. In the adjuvant setting, one has not chemotherapy mandatory, but in the other setting, it is mandatory. And mostly it's platinum-based, some have only cisplatin. We have been seeing in this trial a high level of locally advanced stage 3 disease, which of course makes the trial more challenging because these are the patients who have a high trend and high propensity to relapse. If we want to understand the evidence, we have to keep in mind that there are differences in trials looking at the treatment length and the median follow-up of the trials. Some of these trials which have further reading, for example, the agent trial, which has at the time being a short follow-up, as compared to some other trials which have a way longer follow-up, like the Keynote 671 and the Checkmate 816. So we have to stay tuned to see the long-term results of this perioperative strategy, because we have to keep in mind that the aim of these trials is to improve survival, and long term, is it 5, 10, or 15 years, to improve the cure rate in this specific disease. Understanding evidence is also to rethink about pathological complete response. And as you can see, pathological complete response in all of these neoadjuvant or perioperative trials has been massively increased from something like 5% to 20-25% pathological complete response. And some trials also report major pathological response, which I think will not be standardized. So let's go back to what breast cancer doctors do, look at pathological complete response with something which is a major improvement and a very good prognosis of this patient who have pathological complete response. And really in all trials, very homogeneously, this is massively and dramatically improved. So there's no difference really to be seen between 3 or 4 cycles of chemotherapy, which could be compared between 2 trials. However, we are used in the curative setting to use 4 cycles, and we like to do that. Thinking about the 2-year EFS DFS, which is reported in all of these trials, first thing, it is improved in most of the strategies, adjuvant, neoadjuvant, perioperative. Then, of course, some subgroups might differ, but the magnitude of difference is quite reproducible in each of these scenarios, with something which really is promising for patients. So in the adjuvant setting, both of the trials show a benefit of DFS. And again, we have to look at subgroups to make sure that in the regulation and in the reimbursement, all of the patients or only a subset can be treated. And the neoadjuvant and perioperative, again, a very large benefit in DFS, which varies from one trial to the other ones and by subgroup, but we will discuss it later on. So all of the strategies are very effective and active. However, keep in mind that the patient selection for neoadjuvant and perioperative, which are based on, the selection is based on the staging workup at initial diagnosis, is not the same patient population as the adjuvant population, which speaks for very fit patients who already have undergone surgery and are eligible for randomization after surgery. So this is not the same patient population, and we should always pay attention when you compare the trials that we are not looking at the same groups of patients and exactly the same results to be expected. Looking at the most important parameters, the overall survival, we start to see results coming. Again, it's about the follow-up of the trials. We need to have mature data here. So let's start with the most important. There's one trial showing a benefit in overall survival in the ITT population, the intent to treat population. This is the pembrolizumab perioperative trial called Keynote 671. So this is the first and unique trial which has already shown a benefit of overall survival in all of these patients with stage 2 to stage 3A on the 8th ANM classification being treated with pembrolizumab 4 cycles before and 1 year of pembrolizumab. Then we see very interesting numbers for the neoadjuvant setting, Checkmate 816, so only neoadjuvant 3 cycle of chemo-IO. There is also a different but not statistically significant today. And in the adjuvant setting, in some subgroups, for example, in the atezolizumab trial in the adjuvant setting, if you look at the high PD-L1, more than 50% of the tumor cells expressing PD-L1, then you can see also an interesting benefit, of course, exploratory in the high PD-L1 in terms of overall survival. So something which, again, tells you about the activity of immunotherapy, but also will regulate the reimbursement process depending on the trial design and the statistical assumptions. Keep in mind, Keynote 671, a positive survival. Of course, thinking about subgroups, this is a controversy also for our regulators. So should you really say that maybe stage 2 or stage 3 differ in the fact they benefit or not from immunotherapy? So there are it's interesting, two back-to-back papers looking at trying to do meta-analysis and looking at EFS and overall survival benefit according to stage and other parameters. So on that slide, you can see the EFS on this meta-analysis in neoadjuvant and perioperative. And I wouldn't say surprisingly, but very importantly, a benefit of EFS is seen in stage 3, which was more or less assumed very clearly from all trials, but also in stage 2. So basically, in this patient who sometimes have no lymph node invasion, but also have a tumor which can be more limited, they still benefit from the neoadjuvant perioperative immunotherapy. And this is also true and stands true for overall survival when you look at this part of the meta-analysis where the random effect model gives rise to a hazard ratio of 0.65 for overall survival for this neoadjuvant and perioperative data. So very important to keep it in mind. Of course, the next question, stage is solved. We have to look at PD-L1. The trial is always debatable when you look at the small subgroup of negative PD-L1. So that's where pulling the data together become important because you sometimes need number to really show something which looks significant. It's about having the power to show a difference. And when you do this meta-analysis looking at EFS, looking at negative, intermediate, or high PD-L1, you will see a benefit in EFS regardless of PD-L1 expression, regardless of the stratum of PD-L1 in which the tumor is. So basically 0.74 for negative PD-L1 up to 0.4 in high PD-L1. So again, this is not a discriminant in terms of decision. You should also consider neoadjuvant perioperative in negative PD-L1. So basically incorporating what do we know? So we need to select appropriate patients, meaning that they should be matching the strategy of immunotherapy. And of course, they should match the whole strategy, which is not a simple one. It has multiple steps. We have to determine the best sequence for each of the patients and maybe discuss it with them. We have to do appropriate pre- and intraoperative nodal staging to make sure that we are able to resect radically the tumor, but also to customize the treatment and the risk if needed, and understand all this evidence that you can see on the slide are presented and plan for potential technical challenges which might come in the future at any level of the profession, from the reimbursement to also the management of, for example, immunotherapy toxicity. Of course, the patient selection consideration is something which is well known for you, but what is new? We have to test for biomarker, EGFR ALK, but also PD-L1 and maybe NGS, because in all of these trials in the neoadjuvant and perioperative strategy, apart from one, the 671, the EGFR and ALK patients were excluded. So it's important to keep in mind that this is not the most favorable group to use it. And more importantly, we have now better strategies in this patient population. So with this, I think you have seen all the data today, and it's going to be very important to share together in the future and now what are the interrogations in the field of perioperative strategies. So let me move to this part 2, which is about to get to a cure and making sense of the innovation, trying to understand what are the maybe decision-making parameters and the open questions in the field of perioperative immunotherapy. We have been seeing that we are now at the step of meta-analysis. So the question is, will all patients with stage 1B to stage 3B, according to the 7th TNM classification, benefit from perioperative strategies? The idea to guide the patient into this strategy with immunotherapy has to be discussed with the patient with the magnitude of benefit and, of course, the burden of treatment that you impose. But I would strongly advise to discuss it related to a favorable event-free survival, disease-free survival, and maybe even overall survival in all of these disease stages with your patient. How to decide between neoadjuvant, adjuvant, and perioperative strategies? Answer number 1, the only benefit in survival being seen in the whole population of patients today has been seen in the perioperative setting with pembrolizumab in the Keynote 671. So I like evidence-based medicine, and the evidence-based would guide me to give perioperative strategy because the only benefit in survival, this is the aim in this setting, has been seen with perioperative. But of course, it has to be discussed with the patient. The patient sometimes prefer to have surgery first. So in this case, you have to propose adjuvant. Today, in my practice, I would favor perioperative, so before and after, because we have been seeing an overall survival benefit. But this is an informed decision to take with your patient. Either a preferred platinum-based chemotherapy agent that should be used as part of the perioperative therapy. The question is very relevant because we have been pretty conservative in the past, telling that in that setting of curative intent, we have to use cisplatin. So at the time of the addition of immunotherapy, this has weakened over time. Lots of these trials use carboplatin or cisplatin, with the majority of patients receiving carboplatin. And lots of these trials show some differences, but it can go both directions, better with cisplatin or better with carboplatin, speaking probably with the absence of real difference between the two types of treatment. So I think the community has moved into allowing itself to use carboplatin if you use IO in the field of early disease, early non-small cell lung cancer treated with perioperative immunotherapy. And this is a relief for many patients. How can we balance improved clinical efficacy while avoiding overtreatment and increased toxicity? So the answer is research. We need to go and follow more research to make sure that if you decide to not to deliver, so to shorten or even to derive from what was shown with the perioperative strategy, you need to do it in a relevant manner in the good patient population. So there are many subgroups we consider. Remember, we were discussing PD-L1, we were discussing stage, we were discussing pathological complete response. Can you routinely exclude some stages, some PD-L1 stratum, or some pathological response from the immunotherapy? I think at the time being, it's too early to say. So I would still not do that, but the research will answer this question. We are close to potentially have a bit more responses and I would say a bit more data about pathological response. And I think the stage and the PD-L1 today still needs to receive, whatever they are, the immunotherapy based on the meta-analysis. But we'll see more data very soon about pathological complete response and the benefit in this subgroup. At the time being, I'm still delivering perioperative immunotherapy, even in pathological complete response. Are there any biomarkers that can help guide clinical decision-making? Yes. So first of all, EGFR and ALK disease have better strategies. Adjuvant ALK TKI, adjuvant EGFR TKIs, these drugs are not compatible with immunotherapy, so cannot follow, for example, a neoadjuvant chemo-IO. So you need to know these biomarkers before you start anything in early disease, before you start immunotherapy. PD-L1 is useful for you to understand the magnitude of benefit you expect from your immunotherapy. It might be important for your regulatory environment, but it does not really change your decision if you have access to immunotherapy, regardless of PD-L1. So, but PD-L1 can be informative for you to know what you can expect for immunotherapy. And some people use NGS to make sure that you are not facing another AGA, actionable genomic alteration, like, for example, the ones which are correlated with a poor benefit, a small benefit from immunotherapy, ROS1, RET, NTRK, HER2 mutations. But this is left to you because at the time being, this discrimination has not been done in clinical trials. Can we utilize response to guide postoperative treatment approaches? So radiological responses from neoadjuvant chemo-IO, certainly not, because the duration of treatment is too short. Pathological response, I was telling before, the answer will be coming over time with more research. Of course, looking at retrospective or matched data from clinical trials. To my knowledge, there is one or two prospective trials looking at the neoadjuvant versus perioperative, meaning looking at the duration of IO after surgery. This is the ADOPT trial done in Europe. It's the ANITOP trial, but it will take some more years to be completed because, of course, it's an academic initiative. So at the time being, we have to look at matched data from, for example, 816 and 770, so nivolumab trials. We have to look also at comparison between trials. It's absolutely not convincing, but we have to judge and discuss with the patient from patient to patient and from environment to environment at the time being to decide. Again, to my opinion, I still consider that immunotherapy in the perioperative setting is appropriate even in pathological complete responders. Is there an optimal or minimum treatment duration in the adjuvant setting that we should utilize? So always stay with evidence-based. So the neoadjuvant has no immunotherapy after surgery. The other trials have usually 1 year, so you shouldn't cut it in two. So it's 0 or it's 1 year. Let's be evidence-based. And again, to my opinion, we don't have enough evidence. 671, the pembrolizumab, shows an overall survival with 4 cycles of chemo-IO followed by 1 year of immunotherapy. So that's what I use. I don't change the paradigm. So be evidence-based. It's the duration which was defined by the trial. And last but not least, how does utilizing perioperative immunotherapy approaches impact long-term management of patients? So I think, first of all, curing a patient or prolonging survival strongly impacts long-term management because there's a real difference between trying to control a disease which has relapsed as compared that a patient who has never to experience a relapse. So I think the main aim of everything we do in this early disease setting is to try not to have any disease coming back at any time point. This is not having to face the disease anymore. So the whole management is changed if you can even improve the cure rate or the long-term overall survival using this strategy. Of course, we have to be careful with immunotherapy toxicity, but we are used to treat them and we are used to adapt our algorithm to them. So I think the most important thing is really to keep in mind that the best chance is curing an early disease. So we have to sometimes maybe today over-treat some patients in order to save most of them from the disease relapse. So be maybe doing a little too much today before we know to make sure that you don't lose any opportunity to give better outcome to your patients. So thanks a lot for your attention. I hope these answers might help you getting to the best approach for each individual patient. And remember that when you have hesitations, you will have to solve your hesitations with the data in hand, discussing this data with the patient, because very often he will help you and guide you into the best customized and personalized strategy for him. Thank you for your kind attention.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an educational grant from Merck Sharp Dohme LLC, a subsidiary of Merck Co. Incorporated. To access all materials for this activity, visit peerview.com/AWU860.